And we are live, Senators.
Oh, terrific. It is, again, this is the Senate Health and Welfare Committee and February 9th. And we are still looking at S37 and taking testimony, and we're welcoming some OBGYN residents from the University of Vermont Medical Center. Welcome. What we'll do is we'll introduce ourselves first, and then we'll have you each introduce yourself for the record. So I'll start this time. I'm Senator Ginny Lyons. I represent Chittenden Southeast, which does not include the medical center anymore. I used to represent it, not anymore, but right next door. So go ahead.
I'm Senator Kulik, and I live in Burlington, and I represent Chittenden Central, and you are in my district.
I'm Dave Weeks, representing Rutland County, and I live in Proctor.
I'm Terry Williams, also from Rutland County and from Fulton.
I'm Ruth Hardy from that Madison district. I live in East Middlebury.
So welcome. And I think you probably have looked at S37 as a result of the passage of Article 22 in November. And we're interested in hearing your thoughts. So, and a little bit about who you are. That would be helpful. So why don't you go ahead and introduce yourselves, each of you introduce yourselves, and then we'll welcome listening to your thoughts.
Okay, I can start. I'm Dr. Mackenzie Delzer. I'm a second year OBGYN resident at UVM. I come from Wisconsin. That's where I was born and raised, and I did medical school in Wisconsin as well, but I'm delighted to be here in Vermont for residency. I am wearing a couple hats today, both with the residency program, the Vermont Medical Society, and I'm also a junior fellow with our American College of Obstetrics and Gynecology.
Great.
My name is Mindy Indig. I'm originally from Brooklyn, New York. I did my undergrad in New York and then did my medical school training in Michigan, and was excited to come back to the Northeast to do my OBGYN residency. And I'm looking forward to testifying.
Hi, I'm Lauren Gernon. I'm a first year OBGYN resident at UVM. I did my medical school training here at University of Vermont, and I'm hoping to stick around.
And I'm Dr. Sarah McShane. I'm also a second year OBGYN resident at the University of Vermont. I am a member of the Vermont Medical Society. I come here by ways of originally Delaware and then briefly Virginia and most recently North Carolina. I did my undergraduate and medical school training in Chapel Hill and then in Western rural North Carolina.
Terrific. All over the country. Where did you come from?
I'm from Kansas.
Kansas. Got the whole U.S. here. That's great. So I know that you've been thinking about S37, and why don't you offer your testimony?
Sure, I can start.
Yes. And whatever you have that you could share with us, and we can put on our webpage when you can, that'd be great.
Okay. So first of all, thank you for allowing me the opportunity to come and share my support for S37 today. I chose to do OBGYN because I cannot imagine myself doing anything different. I'm excited every single day to go to work and meet people at their various phases of reproductive well-being, and I love continuing to learn how to support these people. While this was an easy decision for me, it was not a decision that I made lightly, knowing that the political climate can impact the way that folks view and judge and vote for policy that impacts the work that I do, including abortion care. And this is why I support S37. I find it more important now than ever to support and protect my colleagues who offer full spectrum and comprehensive reproductive health care. Just last week, one of my colleagues shared messages that were sent to her personal Facebook Messenger account by an angry community member. And this person had messaged her violent threats and false claims about her abilities as a doctor. As we are subject to this type of violence more than other specialties, it's crucial that we are legally protected by bills like S37. I feel grateful to be in my residency training in Vermont, who has been a leader in abortion policy. Here, I get to learn how to give full spectrum care and how to take care of the people that I'm going to be caring for the rest of my life. I urge you to be a leader once again and adopt S37 as an example to the rest of this country about the way that you value and protect your reproductive health physicians. I've gone to school, kindergarten through high school, 4 years of college, 4 years of medical school, and 2 out of 4 years of residency, and I have a lifetime of learning to go. My job is complex and it's challenging and it's incredibly rewarding, and my job deserves to be protected. Thank you.
So I want to thank the committee for the opportunity to testify for Bill S37. After I complete my residency, my career plans include a fellowship in training on how to provide comprehensive gender affirming care. As I advanced in my training, I formed a network of mentors and colleagues who provide gender affirming care across the nation. There's been a disturbing trend that's become more and more difficult to ignore. As critics of gender affirming care become more and more vocal, that has threatened the safety of my mentors and their families. That one of my mentors in Boston has gotten bomb threats to her office, necessitating her hiring a full-time bodyguard for a month because those were validated, credible threats to both her safety and her family's safety. Another mentor out of Michigan had letters sent to their house, which is not a public record, detailing threats to their 6-week-old newborn, and what sent there because of the gender affirming care that they provide. These safety concerns have continued to increase at an alarming pace. I'm worried about the future of gender affirming care and the toxicity of such an environment. I'm worried for my safety and the safety of my family, and I'm worried for the safety of.
Can you increase your?
Yeah, I'm worried about the safety for myself, my family, my friends, and my colleagues, and I'm worried about the ability of us to provide comprehensive gender affirming care to gender and sexual minorities. And so I ask that Vermont affirm their commitment to the safety of these providers by passing Bill S37. And I thank you for the opportunity.
Thank you. Terrific. I mean, what you have said is unfathomable. Yeah, inappropriate things that are going on. Do you two want to share something further?
I echo both. I think they spoke to a lot of what we all care about and why we're all in Vermont. It's an incredible privilege to train here. And I think as things change politically across the nation, even my colleagues that I graduated from medical school with that are in other states, their training is looking very different now than what they thought it was going to look like when they went into their programs. And so I think first and foremost, I'm so grateful that I'm here and learning. And I think as we look forward, you know, the graduates coming out of Vermont programs and states that are doing protections like these are going to be the future of healthcare providers for Vermont, but also for a lot of disenfranchised places in the nation. And I think that this work that you're doing is setting a really good like leadership and example to the rest of the country.
Yeah, and I would say I purposely left Kansas for my medical training and came to Vermont, and I'm staying here to do my OBGYN fellowship residency because of the protections and the availability of learning a comprehensive OBGYN training program that isn't available everywhere. And I think passing a bill like this while we're in training is a sort of incentive to stay, to be here when we'll be out in the community giving care and being protected and giving that care. You can't get that everywhere. So.
Yeah, I mean, there's so many questions that just sort of begin as you're talking and thinking about the road in front of you and what it would be like somewhere else. It's just very concerning for one, but I do have a couple of questions for you just about your residency program. Have you encountered instruction around gender affirming care in your program to date? I know you're first year, but the second year folks, you've seen that, and so you're linked in with the pediatric folks, and Erica Gibson and Dr. Gibson in particular. Yeah, it's good. Are you interested in a fellowship where?
I'm interested in the fellowship is pediatric adolescent gynecology, which unfortunately does not exist in Vermont.
Yeah.
And so I'm hoping to stay in the Northeast, and so I'll be applying broadly. We'll see what we get.
I don't know.
There's
New York.
There isn't any in New York either, which
There
is
isn't?
weird. There's a few in Boston and in Philly. So,
Okay. What's the landscape like in Pennsylvania?
very variable based on the districts. I think, in Pittsburgh and Philadelphia, they're different than in more middle Pennsylvania.
Yeah.
So I think it's a little different, but we generally practice evidence-based medicine based on our governing bodies.
Yeah, I mean, it's hard to think about going forward and starting a practice when you hear about the threats that are made to personal threats that are made because of professional expertise and practice. Yeah. And the other question I know that comes up frequently is the issue of liability and what you're thinking about that. If you, as you looked at S37, what were the thoughts that came to mind around liability or other areas? I mean, because obviously you've looked at the bill, so maybe some of your thoughts there as they, your personal thought, your personal professional thoughts there.
Yeah, I feel like physicians should be held to the standard of offering options that are safe for their patients. And so we're in this complex training program to learn about all of the safe options. And, having some legal protection behind us in knowing that like the frame that I'm gonna come at forever is gonna be what is safe for my patient and how can I help them achieve their health and reproductive goals and be a member of society that's contributing and building a family that they want to build. And so, I think it's sad that sometimes we need to write some of these protections into place. But I think, at the end of the day, we should be held accountable for just helping our patients make safe decisions.
Thank you.
And I think one thing that I was thinking of as I was reading the bill is particularly to medical malpractice. And I think our malpractice rates as OBGYNs is particularly high compared to other specialty because we have a patient and their family at the same time. And so we're responsible for generations, which is appropriate because we should appreciate the intensity of that role. But if you add additional liability to our malpractice based on things that are not related to medicine and they're related to political thoughts, then it seems like a unnecessary side effect of something that our medical malpractice should be protecting us from making medical mistakes and doing injury based on medical care to apply to a physical social climate.
It occurs to me it might make you overly aggressive in treatment and so maybe you speak to that a little bit.
Yeah, I think we are lucky in Vermont that our medical malpractice does not guide decision making as much as in other states. And we appreciate that, is that the primary thought in our decision making is what's best for our patient and their care. Other states do not have that privilege because of a more litigious environment. And that definitely can impact the quality of their care because they're not thinking about what's best for their patient. They're worried about are they going to get sued.
Thank you. Any other questions? Go ahead. We'll start with Senator Gould and then we'll go to Senator Williams.
I just want to say thank you all for being here so much. You are clearly compassionate, caring, incredibly hardworking, and an adjective that I wouldn't have thought I would need to use to describe physicians 20 years ago. You're incredibly brave. So I really appreciate what you're doing. I wanted to follow up on something that you said, which I think in our committee we need to consider. This bill has so many wonderful aspects to it, but I guess I hadn't really thought about in terms of labor force and job creation, what this means to our state potentially. And I think it's really important because, we're in the midst of a labor shortage and we're kind of looking at everything through a lens of labor and economic development. So I appreciate you bringing that up. And I think it's, again, really important for us to look through that lens as we look at this as well. So thank you.
And I agree with everything that Senator Gulick just said. And having been schooled in the school of life, I know that there are always two sides to every story. And I'm just curious if you got any of your colleagues that don't support S37. I mean, do you ever have discussions about it? They're going to be in your careers and in your lives. There are going to be ethical situations that arise that you may not agree with, may not support. And some in Vermont, especially some medical institutions won't allow you to not perform an abortion or gender affirming surgery. So I'm just wondering, have you had anybody in your profession that didn't support what S37 is you're aware of?
I think you're saying that there are individual practitioners who might,
Correct.
yeah, have a conscience or different opinions, beliefs, but nothing in the state of Vermont legally will prevent them from carrying out for their doing their own work here.
Right.
Yeah, yeah,
But if the situation changes,
yeah, well,
that
yeah.
they may have to do it even if they don't agree with it.
Well, I remember something, I just want to clarify something. Our Constitution now protects whatever is in S37 in terms of abortion, so, but,
Article 22.
yeah, Article 22. Oh, okay.
But no one could ever, like, as a provider, I might have a different comfort with certain procedures versus other procedures than a different provider. And every provider gets to choose what they are going to practice in their own practice. And so no one could ever force me to perform an abortion for somebody, nor could they force a nurse or other healthcare staff. It's an opt-in environment. And so there are certain providers who may choose that for whatever beliefs or experience or expertise that they have, that they might not perform surgical abortions themselves. But I don't think there's anyone that I've ever encountered that would object to their colleague being protected for what they choose to practice.
Oh, I understand that totally. Okay.
But, I mean, what you're hearing from a group of people who have considered ethical, have considered ethical decisions and ethical guidelines for the work that they do. And
they all support S37.
And they all do support S37. And it's not a bad thing. I think it's a great thing. And it's putting us in a place where your professional and protected healthcare standard of care, your standard of care is protected through licensure in the state and through our state laws, which is quite different from what happens in other states. And so the ethical quandary that we see going on with OBGYN folks in other states is not here. There's some firm ground upon which you work. Senator Hardy has a question.
Thank you, Madam Chair. I just want to reiterate what's your name?
McShane, yeah, Sarah McShane.
Dr. McShane said is that there is nothing in state law or federal law or in S37 or in Article 22 that forces a healthcare provider to provide care that they have a conscientious objection to. Nothing. That is period.
Okay. Just learned something.
Yeah, and so then I also want to ask you, because you're all from different parts, I mean, Wisconsin, Kansas, North Carolina, New York. The three of you in particular are from places where abortion care and transgender care may not be protected, is not protected, basically. It's just not protected. And North Carolina is sort of
We're on, yeah, on
we're
the
iffy right now, but I'm just wondering how you're feeling about, this is a big question, and I mean, you've sort of touched on it, but like your future about practicing in your home states? Or, you know, how are your colleagues or friends back home dealing with these issues? Are there residents in Wisconsin and Kansas, and North Carolina who are coming to their state legislatures and testifying against bills that are doing the opposite of what S-37 is, sort of like the state of your generation's doctors?
That's a good question. Are they speaking out? I mean, are residents, your peers across the country, speaking out against a limitation on the potential for practice? The answer, can you articulate your answer a little bit?
I have not talked to the residents at Wisconsin.
Okay.
This is my cohort of people right here, and so I think that's a great question and something that would be of interest to learn.
I have colleagues in
And
Wisconsin.
Yeah.
But I have a lot of friends from medical school that also went into OBGYN and landed in different parts of the country. And as we were applying, people who cared a lot about learning these skills were looking at certain areas of the country where it's easiest to practice and you get the most experience. And I think that has changed as legislature has changed even since we matriculated into residency. And so I think that I'm going to have colleagues that perhaps, whether it's because they end up practicing in a state that political climate they feel is dangerous and they choose to make a personal decision around the safety of their families, or whether they didn't get the training that they were hoping for in residency and don't feel skilled enough to provide certain practices, then might end up not practicing when they had wanted to previously.
I think in Michigan, for example, I've had colleagues and friends who have gone to testify in environments that are a little more contentious regarding some protection for abortion or gender affirming care, because it's, definitely there are some states where those rights are a lot more at threat than Vermont. And you all know, colleagues, in the last 6 months, we've had to take jobs in other states because the breadth of their practice were limited by new laws. And that's always unfortunate. The people who lose are the people who live in that state and don't have access to services they need because the providers are not protected in those states, which is the people who suffer the most at the end of the day.
Thank you. Yeah, Michigan's just a little better,
A little better.
but it still takes courage to step out and speak. And we do appreciate your courage in being here. The bill itself is unique, a little bit unique. A couple other states have done this, but it's important for you to be supporting the practice of medicine. That's what it is. How medicine is practiced. Yeah, we appreciate that very much. So thank you. We're glad you're here. Do you have anything else you'd like to tell us?
This has been a great conversation. Thank you.
Oh, it's been good. We'll do it again. We'll have to get together again. Appreciate your time and your work, and good luck with your careers. Maybe some of us will see you back in Vermont here more permanently. So thanks.
Thank you so much for this opportunity.
Okay.
Appreciate your time.
Take care. Good luck with your fellowship challenge. Medicine now looks good. Okay, so we're gonna move right along to our Green Mountain Care Board. They are in the bill, and I've asked them to come in and testify about the sections of bill for which they might be held responsible. So welcome. You heard us, did you hear us introduce ourselves earlier? Because I don't think you've been here before, Lindsay or Kate. Yeah, okay.
Yes, we did. Thank you.
All right, great. So why don't you introduce yourselves for the record, and then we'll have you present your testimony.
I'm Catherine O'Neill. I go by Kate, Health Services Researcher at the Green Mountain Care Board.
Good morning. My name is Lindsay Kill, and I am one of the analysts at the Green Mountain Care Board.
So good morning, Madam Chair. Good morning, members of the committee. Thank you for the opportunity to speak with you today. We do appreciate the value of reporting and understanding the landscape of access to services that are described in S37. It's my understanding that where the Green Mountain Care Board is named is in section 9 with regard to a report. If there are other sections that I missed, please let me know, but what we
That's it.
have done. Okay, great. So we've come prepared today to provide an overview of our data resources, including what we do and do not collect and the limitations within that data, if that is what is of interest to the committee. But if we're off the mark at all, please let us know. We are certainly interested to learn from the committee about how the Green Mountain Care Board can support this work that's outlined in the bill. So just a brief overview of the Green Mountain Care Board's data assets. I'm going to do this very, very briefly. Be happy to come back at another time to help the committee understand the data that we steward in more depth if that's of interest. But the Green Mountain Care Board stewards 2 databases related to healthcare insurance claims and hospital services. And so one of them is VCures, that's Vermont's all-payer claims database. And VCures contains insurance claims from commercial, Medicaid, and Medicare for insured Vermont residents. And that's for Vermont residents wherever they receive their care. The other database that we have is, we call it VUDS, and that's Vermont's hospital discharge database. And VUDS contains hospital admissions and discharge information and emergency department information for just Vermont hospitals. So VUDS contains data like when and why patients were admitted and discharged, though that data set doesn't contain provider information. So I think it's important to note that VCures and VUDS both are de-identified data sets, and they are, we call them administrative data, right? So none of the data that's in those databases or that the Green Mountain Care Board has access to is actual clinical data. I also would like to mention that we're the steward of both of these databases, and this stewardship is overseen by the Green Mountain Care Board's Data Governance Council, and that both of these databases are available to the Green Mountain Care Board analysts and other state agencies that have secured with us data use agreements, and these databases are used for research purposes. So we definitely use them robustly and do a lot of research. With regard to this bill, however, we think that VCures and VUDS are not likely to be very useful data resources because there are a lot of limitations about what data are collected or available with regard to the services in this bill, as well as for the data that we can see, the numbers are just very small. So what I've done is I'll talk about abortion services with both of our data sets, and then I'll talk about the gender affirming care services. So with regard to abortion services, in VCures, our claims database, provider information related to abortion services are classified as unavailable. So functionally, what that means is abortion care claims do not have individual providers, organizations, or other geographically identifying information. And this has been the case for many years, if not for all of the existence of VCures. So VCures was established in 2009. I came to the board sometime later. So that's an important limitation. We cannot see provider data related to abortion care. Also, in VCures, the pharmacy data is limited, which may be a result of people paying out of pocket for abortion medication. We don't have estimates for how many people self-pay for example, for these types of services in Vermont. And also pertaining to prescription drug services, VCures, our claims database, only has data from insurance claims, right? So it's not clinical data. So while we might have data on prescriptions that were filled with an associated insurance claim, we can't see anything about prescriptions that are issued by providers, but say not picked up, or prescriptions that are paid for outside of an insurance claim. With the hospital discharge data set, that does capture inpatient and outpatient abortion-related services. And we did a quick look this week in the VUDS data set for the year 2021. And we can see some hospital discharge data related to abortion care, but the overall numbers are very small. So we don't have estimates for how many people get these services in hospital facilities, say, versus other facilities like family planning and that kind of thing. Now, with regard to gender affirming care services, we can count numbers of patients receiving care. We looked at both data sets, and we can see that some claims and some hospital discharge data on gender affirming care services are available, but for sure, we're seeing small numbers. And that would mean that it's likely that we would only be able to report an aggregate. And for some of those services, we may only get a statewide view. So in VCures specifically, outpatient surgery, this might be getting into the weeds too much, but outpatient surgery is billed on a professional claim. So it just makes it not easy for us to really see the location of where services were provided, because it largely depends on the billing provider and where they're located. And again, in VCures, we're only going to see insurance claims. We can use provider address information if it's associated with an updated record. This is another issue that we have, because providers, they don't often update their information unless they're registering with new insurance. And so we don't always know if the provider address information is up to date. I think I'll stop. I'll say that in the hospital discharge data, we do see that the data does capture the diagnosis of gender dysphoria in youth and adults, and associated inpatient and outpatient emergency department services. The list of associated services is very broad. Again, though, we're seeing small numbers. So that's all that I had that I wanted to just share in terms of an overview, which is very specific to Section 9, looking to establish a report around the sort of the proximity of healthcare services. And so I'll stop there. If you have any questions for us or thoughts, we're very happy to help with in any ways that we can to help shape what a report could look like that could be meaningful. And so I think I'll stop there and see if you have any questions for us.
Yes, thank you. I do have some questions. I have some comments first, and that is, we don't want to put any of the centers that are providing this kind of care in jeopardy. Certainly, disclosure of patients and practitioners that might put them in jeopardy is not something that this section of the bill is trying to do. We're simply trying to understand where care is available in the state. So, and my question sort of goes to the HRAP, the Health Resource Allocation Plan, and what OBGYN facilities might be available across the state, which is less prescriptive than looking at specifically abortion care. So that's one. And then the other is there's a needs assessment that's going to, I think the RFP is being completed or going out, or however that's happening, with Act 167, looking at statewide needs, both community services and hospital services. So for me, making the link there to those two things might be something that we can think about, all while understanding the issue around confidentiality and for our providers. So maybe, can you just talk briefly about those two, the HRAP Act 167 needs assessment? And if there's something there that might elucidate what we're looking for?
Sure. So with regard to HRAP, I can look and see if we even have some of that information already available in terms of OBGYN facilities. If not, that is information that that we may be able to learn about. I will note that with regard to HRAP, a lot of the data that makes HRAP possible is collected in other ways. And so what we may do is see if we can find other resources that can help with that. And so and then link that to HRAP. So that's one thing. And Act 167, yes, it's I think that the RFP is still out. The contract is not yet assigned, but once that happens, one part of that is data collection, and then working with communities in the needs assessment process, the community engagement process. I think that could be an interesting opportunity because it's my understanding that in that section of that contract for Act 167, the contractor would be working directly with communities and engaging directly with the communities within Vermont to understand needs and resources. And so we can put a pin in that for sure.
That's great. I mean, that's good. And then at the same time, putting a pin in the hospitals who are providing the care that's in that section. That would also be helpful. So that would give us the idea of the 50-mile radius, somewhat of an idea. And certainly any FQHCs that show up during this process. And I know that you're working collaboratively with AHS, so that I can see some opportunity for us to modify the language that's here in the bill, and would very much welcome your suggestions after this discussion as to what work. Yeah, that'd be helpful.
Sure.
But Senator Hardy is at the edge of her seat, so we'll have.
I just thank you, Madam Chair, and I wanted to sort of play off of what Senator Lyons already mentioned. The reason that you're named in the bill is precisely because of the HRAP process that you do to identify services and facilities around the state, and also the work you're doing with 167. So again, we did not imagine the intent of this is not for the granular patient data. It's much more for access to services and facilities around the state for both abortion care and gender affirming care. And in large part because we've seen facilities close with some of the Planned Parenthood clinics around the state close, and what has that done to access in some of the more rural parts of the state. And gender affirming care is really hard to come by. So needing to find, where is it available? I mean, right now it's mostly Chittenden County, and how can we work towards making sure that care is available in other parts of the state. And I mean, I don't know if you heard the testimony this morning from the Vermont State Universities. They're in parts of the state where there's not readily accessible care in some cases. And so making sure that wherever Vermonters are in the state, they have access to this care. And unless we have a report that shows where it is, we won't know where we need to improve the care. And if you're not the right agency to be, or organization to be working on this, suggesting who might be is so helpful.
Okay. Yeah. Thanks. I appreciate that. And we will definitely talk about that as a team, and we'll loop in the members of our team that work on HRAP as well as Act 167, because I think there could be some interesting opportunities there. The abortion provider issue is a real one. We don't collect that data, and I don't know where else in the state that data is collected. So but I know we don't have it.
So
So,
look at, we understand the
Yeah.
limitations that you have, but you also are in the process of the community engagement. And that
Sure.
may be very informative. So as you're thinking about modifications to the language, as we will, we don't want to exclude you because you do have the HRAP and you are a big piece of 167. So we'll be adding some language here that will include some outreach or connection with Department of Health continued, hopefully, and perhaps AHS and perhaps other stakeholders who, I don't like that word, but other folks who are engaged in this important work. So
sounds good.
I really appreciate your testimony, and we understand that this is not about personal clinical information, nor are we targeting providers in any way. We simply want to know accessibility. We want to know about accessibility, and so it can be a more general report. And it's not necessarily a report as much as it is showing us the map and bringing in information in a presentation form. So we'll work on that as well. Senator Weeks.
In addition to a map,
Yeah.
show a kind of geography of access.
Yeah.
Isn't also one of the goals, kind of like figuring out what the population is in there?
Yeah.
And, you know, map is good, but if it's 40% of the population versus 5% of the population,
Sure.
that would be helpful.
Yeah, the 50-mile radius, I think, is kind of expressive of that. That helps, and that's on it. That would be available through HRAP. And I know the FQHCs are also involved in some of this, so we'll have to include them or as some of your interested parties without using the word stakeholder. That's a good point, sir. Okay, anything else that you would like to share with us or questions from the committee? Okay, we're good. Thank you so
Great.
much for being available.
Thank you. And
So
we look-
there's a little homework here in terms of connecting with us and with Alex and with our Ledge Council. I'd like you to do that on language. I'll be working with Ledge Council to improve the language that we have in front of us. So it'll be an iterative process. And then the committee eventually is going to have to put a stamp of approval.
Great. Yeah, that's great. We will do that.
Okay, we have not heard yet from the Department of Health on this section, so there's still a little bit of work to do.
Okay.
Thank you.
Thank you.
Greatly appreciate it. Take care.
Bye.
All right, so we're gonna. We have two roads to choose from, the path. One is to continue hearing from Ameren and Jen. Is that something, or are you interested in moving forward with the work that's going on the floor? Like to finish going through the bill with us now. Can we do a little bit of that?
Yes, certainly.
Let's do that. And we'll try to finish about a half hour early at least. But
I think just one observation.
uh-oh.
Yeah. So I've spent a career working in a variety of goals, which some would focus on the overall mass population, some would focus on the individual. The optics, today we got word that Castleton University Library just slated to close for cost saving measures. And just again, optics being what they are, so in one scenario, we've got a university which is losing a facility that caters to all the students. On the other hand, we're considering services which focus on a subset of the same population. And it's just having a little trouble dealing with constituents who don't understand the map, the focus on the mass versus the focus on the individual, and find ourselves in a kind of an unusual place. I'm not asking anybody to
Let me offer a comment. So what we're doing in here is we are really protecting professional practice. And so we're ensuring that professional practice is protected on college campuses so that kids who need those services have them available. And one of our roles is to look at our public institutions and ensure that all services that are legitimate, protected healthcare services are at our public institutions. So that's one. The library issue is huge. And I have my own thoughts about that, as I'm sure that you will, and in education, I hope you dive into that. Senator Goulart.
May I address my comments to my esteemed colleague? So I'm a librarian. They're not, and I want to weigh in, they're not actually closing that library. They're shifting to an online format from hard copy, which to some of us is tragic because we like books and paper, but it is sort of the trend with libraries. And as sad as it may be for some of us, I do think a lot of young folks don't read paper anymore, and they like to receive their scholarly journals, etc., online. So it's not quite right to say that they're closing the library. That's not my understanding.
And this is a really important conversation for you folks who are in the education
I just
committee.
wanted to
And
say that.
we'll all be weighing in one way or another. Yeah, totally. And then we're not going to talk about it any further. Senator, did you want to comment on?
I just more just generically about the sort of balance of conversation that we're having in here about one thing and a conversation that is relevant to another committee. That happens all the time, and we get constituents saying, why are you doing this when there's this other problem that needs to be solved? And I think that we, because of our committee structure and because of the dedication of the legislature, try to tackle as many problems in our state as we can. I really, really sincerely believe that, and I've observed it over my 2 terms here. And we can't solve all the problems, but we really, really try. And so I think answering to the constituents of, I hear you, I'm sad or worried or concerned about this too, and we're also concerned about this other thing, and we can do both at the same time, or we can work on both and try to solve both problems. And I'm happy to talk to you about that further, because I think just because the libraries are closing or maybe closing or changing doesn't mean that we shouldn't be tackling this incredibly important topic over here.
So that's an important conversation, and we'll have coffee. Yeah. All right. This is good. So back to the bill that we are working on. We were on section
6.
We
We're just starting 6.
Let's just go there. This is a nice way to refresh ourselves about the testimony that we've heard. Come back to it another time. So here we are on professional conduct.
Yeah, so we're now moving into professional regulation, section 6. If you recall, there are 2 sections on professional regulation. The first one concerns professions regulated by the Office of Professional Regulation, and the second concerns professions regulated by the Board of Medical Practice. So we heard testimony from the Office of Professional Regulation on section 6. Some specific requests about language, such as merging subdivision 1 and 2 in subsection F on page 9, because according to OPR, the process is all part of one process, and there's no need to distinguish between the 2 which is to say, distinguishing between disciplining someone's license once they're already licensed, or disciplining or otherwise not permitting someone to be licensed as part of the application process. So the recommendation was to combine the two of those. I believe the Office of Professional Regulation mentioned that they were aware of the definition change to legally protected healthcare activity in H89, but I do not know whether they had a chance to fully review it since it was that morning, I believe.
I think they were just, I
or they
think they
didn't.
were waiting to see what would come over.
Mhm.
Yeah, I don't remember that piece.
I remember it being mentioned, but not an opinion one way or the other about the definition coming from the House. And then for the next section, on professional conduct for the Board of Medical Practice, you heard fairly lengthy testimony from the executive director there about with a number of concerns, both specific language, but also policy concerns about the direction of this paragraph. Some of the specific language changes were making sure that subdivision 2 also included the word solely, and some other comments about making sure that how the language is worded both in this section and in the definition of legally protected healthcare activity, that you are not inadvertently overly binding the Board of Medical Practice's ability to discipline someone for endangering patients. I believe one of the example was we would want to be able to discipline a provider who has a criminal conviction in another state. And so I am not sure whether he had seen the definitions in H89 yet. He did not reference them, so I'm thinking maybe he was looking at just the definitions in this bill, so that opinion and thoughts on the section might change. There was also the larger policy question that he brought up about whether we are protecting providers who are providing these services through telehealth in a state where they are not licensed. So there was.
Can I ask about that? So that was something I was, I guess, confused about and wondered your thoughts on this, because my understanding, and maybe I'm misunderstanding this, is that in order to provide healthcare in another state, and the example yesterday was Alabama, but it could be any state, you have to have a license to practice there, even if you're providing telehealth to somebody in that other state. And I didn't think we were changing that in the bill. I know that we got a request to do that yesterday, but then I just sort of got confused as to where we were at with this in the bill.
So, yes, so I think as a starting point, this is an issue that started being flushed out in more detail once people really started digging into H89.
Okay.
So the initial definition that we have talks about providing services to a patient regardless of the patient's location. And then the question came up, well, what if the person is not licensed but providing those services to? So I think as part of the conversation that's gone on in the House is trying to flush out where that policy decision is being made. And so that's one of the aspects that you will see in the current as proposed H89 that's headed to the floor today. You will see that there is an explicit policy decision made about whether that is or is not okay.
And what was the policy decision made as it goes to the floor? Where are they at with it?
I should pull up the language specifically.
The bill will come over.
Yes.
Once it's voted on in the House, and then,
Yeah.
then we'll drill down and see what is there.
Yeah, I mean, that's fine. I'm just trying to clarify my confusion at the moment.
Yes, I would say that the definition that is in S37 and that was originally in H89 was not, it could have been interpreted in different ways.
Yeah.
And people were interpreting it in different ways.
Right, clearly.
And so House Speaker
clarity.
Sherry said, we need to clarify one way or the other so that providers know what's happening. So currently there's now an exception Let's see. Okay. The provision of a healthcare service by a person duly licensed under the laws of this state, meaning Vermont, and physically present in this state, Vermont, and the provision of insurance coverage for such services shall be legally protected if the service is permitted under the laws of this state, regardless of the patient's location or whether the provider is licensed in the state where the patient is located at the time the service is rendered. So this clarifies that the healthcare services would still be protected even if the provider is not licensed in the state where the patient is located, so long as they are licensed in this state and are physically present in the state, and so long as they are providing care up to appropriate, appropriate standards of care that would be, so long as what they are doing would be legal in this state by our standards.
So that would cover the instance that the doctor we heard from yesterday, where she was providing healthcare services to patients in Alabama where she's not licensed, but she's licensed here and she's physically here. So it would be through telehealth. So maybe talking to a patient about medical abortion or whatever. Is that right? That's the way H89 is.
As it is headed to the floor today, yes.
And did the medical board of practice,
We'll get to
did
that.
they testify in the House on it?
I don't know if they testified on that.
Right, that definition I think was being worked out until close to the end, so I don't know if
Okay.
there was testimony on that. That's the definition we want you to focus on when it comes over here.
Okay.
I also think it's just important to remember that Vermont can't authorize a provider to practice in another state if they're not licensed in that state. What we can do is affect how Vermont's licensing board and Vermont's laws would affect that provider in Vermont.
Period.
So we can't authorize a Vermont provider to practice in Alabama.
Right.
We can only say what we will or will not do with that provider if they are providing services that would be legal here in that other state. And in some cases, regardless of what that state may do around unauthorized practice or otherwise.
So in the case of Alabama could raise an issue about that practice of medicine in Alabama. I mean, they could raise the issue.
Right,
And so this is why the Judiciary Committee is going to take a keen look at the definition as well.
Right, so that's where some of the provisions in Act 80 or in H89 and the provisions in this bill are trying to get at the various sides of what the state can
So
control.
we're not the
But
judiciary.
recognizing there are some things that are simply out of our control.
Okay.
Yeah, good, thank you. It's good discussion. Anything else there?
In terms of these sections, I don't believe you heard any testimony about the definition of healthcare provider for these sections.
Okay.
So I would just flag that to make sure that this covers all conceivable professions that you are looking to cover, and make sure that those entities that are regulating in these sections, the Board of Medical Practice and Office of Professional Regulation have the same understanding that you have about which professions may be covered.
Yeah, we did get a question from one of our colleagues about mental health providers and whether they would be covered in social.
So, so we're gonna have to go to that. About that. And the other thing that keeps swirling around is the telemedicine bill, telehealth bill that the House is gonna be working on. It'll come to us. Any relationship there, I can't believe that. So which section, are we still on healthcare providers? My brain went off somewhere. I want to make sure I'm coming back.
Yes, I think we had about wrapped up the professional regulation sections.
Okay. So why don't we go? Now, I have a question before we dive into subchapter 11, section 8 on the Pregnancy Services Center. The question has been brought up about we're targeting one kind of center here. and trying and defining it. And the question is, shouldn't shouldn't deceptive and unfair practices relate to all healthcare centers that are providing abortion, pregnancy, birth, whatever? Why is it necessary? The question is it necessary to target one type of center? And this is kind of the legal question.
Well, I would say that is really a policy decision.
It is a policy.
When you're looking at, there are certainly, how we would draft language would vary depending on what scope you decide to cover for various entities. Certainly the narrower the scope becomes, the more, I don't want to say the more likely there could be a lawsuit, but when you were talking about speech and either limiting speech or trying to provide protections or guardrails around speech, just by the nature of focusing on speech and focusing on a specific type of entity speech, you are more likely to see lawsuits in those arenas around First Amendment rights. So I would say if there is a particular problem that you are seeking to address and it needs to be narrow, I mean, normally we do like to narrowly tailor our laws to address a very specific problem. And if it looks like the problem needs to be addressed with narrowing the scope to particular types of entities, then it would be appropriate to narrow the scope. That doesn't mean that there couldn't also be a lawsuit, but I think trying to define where the problem is and then figure out the best way to address that, what scope and what would be appropriate guardrails to put in given free speech and other constitutional considerations.
So in terms of this bill, then the scope is narrow.
It is narrow.
And so it is more appropriate to have the narrow scope. And I wanted to clarify, I'm just really trying to clarify this because the question has been raised. I know that there's a bill introduced, I think, in the House around consumer protection, and it's broader. So having a narrow scope for kind of deceptive and unfair advertising, marketing, and other practices, which does include speech and communication, having that narrow scope is more appropriate constitutionally. That's all I'm just asking that question.
Okay, and
Yes.
so, I mean, I think what Amber was telling you is really, it depends what problem you're trying to solve. So,
We are
if you are hearing concerns about several types of facilities, then maybe you want to tailor your law to address several types of facilities. If you're really hearing about a particular type
Yes.
that you're looking to target, I think that's what she's referring to as kind of narrowly focusing in
Yes.
on that particular type. So I don't think we're necessarily telling you you should be narrow or not
Do
narrow. It
one
depends
or the
what-
other, but.
what the problem is that you're
Yeah.
hearing. and that
So,
you're
but the
trying to
problem
address.
that has been identified is the one that's in the bill. And we're not hearing it about multiple clinics and hospitals and everything else. We're hearing it about one type. So that's important to clarify in testimony and on the record for us in the committee. And we have, and that has happened. So, but. Appreciation. So that's.
Okay. So,
for-
yes, did you want me, we also heard, I believe only one witness yesterday testified about this section, which was
Yes.
Planned Parenthood of New England, who raised a couple of alternative options rather than doing this language, which would be to pursue a professional regulation slant, such as if they're providing or seeking to provide medical type services without appropriate licensure, or coordinating with the Attorney General's office on more of an education campaign around these issues so that people are clear about where they should go for what type of service they're looking to receive. So those were part of the testimony yesterday from Planned Parenthood of New England, and also expressed the concern about the possibility of litigation with this section. So,
We also heard, and they didn't include it in their testimony, but I hope they will. I don't know if they provided us the language, but from OPR about the regulation of the healthcare providers who are associated with these facilities. They did Lauren Lehman send in her testimony yesterday from OPR?
I don't think it's here yet. I'm not sure we've seen it yet.
Alex, can you reach out?
Yeah, because I had asked her to include language about that, because as you know, I talked with Lauren Hibbert about it. She had suggested some language to get at the professional regulation of licensed healthcare providers who are associated with the crisis pregnancy centers. So I think we could.
Well, we'll reach out, because I know she did mention that.
Yeah, and I think the narrowly tailored language is appropriate for the problem we're trying to solve, Madam Chair.
All right, so
Next section.
go right ahead.
All right. Next, we're moving into reports. Section 9. This first report, if you may recall, we just were hearing testimony about this, both from the Department of Health and the Green Mountain Care Board, about identifying areas of the state in which people do not have access to abortion or birth care or gender affirming healthcare services within a 50-mile radius. So it sounds like we've already had some brief thoughts on maybe amending that language.
Yeah, I think what we'll do is we're going to hear testimony from the Department of Health, and conceivably they will talk about this section as well as the section on the colleges. So this is a continuing dialogue, this section. Yeah. And maybe Green Mountain Care Board will get back with some language.
Next, section 10. This is another report, this time from the Board of Medical Practice and the Office of Professional Regulation. This is about the interstate compacts. This would be a future report out in November 2024.
OPR said they'd do it.
As compacts and compact language evolves over time, having an understanding of what those compacts, what impact those compacts might have on the laws that you are looking at proposals. And those are the end of my section, so I'm going to turn it over to Jen.
Okay.
All right, with the caveat that I didn't hear yesterday's testimony, so.
I'll chime in.
Oh, great. So section 11 deals with emergency contraception. And I know there's been some communication from advocates around the immunity provision for pharmacists. Otherwise, I'm not sure what other.
There was I think that there was a standing order previously, and it was rescinded in 2016, we know that. And then when it became an over-the-counter.
Right, some is available over the counter, some is not.
Some is now not, so this is looking for those that are not.
Right, also looking at, I think, allowing the provider or the pharmacist to prescribe may pull in some insurance coverage that wouldn't be available just purchasing over the counter.
There are some current concerns about folks who are already on medication and then getting this medication and what kind of effects will they have, so.
And there is language in here that, because I took it from the old version, the former version of this law that specifies that before dispensing emergency contraception, a pharmacist may complete a training program approved by the health department. So you may want to think about changing that to a shall if you're concerned about whether the pharmacist would be aware of potential contraindications.
I think this is another place where the Department of Health is going to be weighing in.
Yep.
Yeah, so we might want to just hold is there anything else?
Did you have?
Yeah, I'll just add one more thing. I recall during the Office of Professional Regulations testimony, there was discussion of whether the best way to do this would be through a standing order or whether to go through a current, I believe she referred to it as a state practice where the department has the authority to specify certain medications that
Was this the clinical pharmacy, the list in the clinical pharmacy
I think
statute?
so, yes.
Yeah.
Yes.
Okay.
So
Yes,
whether
so that
to
would be
add-
another way.
Right, and it was the difference between being authorized to just dispense and being, or having the authority to prescribe and dispense.
Right.
Right, so
So
that was
the
a
prescription
distinction.
piece would get in the insurance.
Yeah, so that was the
Because it's
distinction
just
that OPR made.
Right, and that's a list that's held by the Commissioner of Health, correct?
I think most of it is statutory.
Yeah.
Oh,
Look at, yeah, it is
statutory.
statutory. It was just added a couple of years ago. In the pharmacy statutes, there's a list of certain types of medications that can be prescribed by pharmacists, and it's under either a collaborative practice agreement with a physician or a state protocol from the Commissioner of Health.
Okay,
So yes, we could certainly look at adding it to that, and adding emergency contraception to that list instead or in addition. Just make a note.
Then are we on the vending machines?
And then there are the vending machines
And OPR wanted to put a may instead of a
around their rules.
board.
right.
Yeah. Then education.
Then we get to the higher education. So you heard some testimony about this morning. These are the readiness plans. This language came, as I think Senator Hardy said, from Massachusetts. Which, although ours is broader in this bill to include the gender affirming healthcare in addition to medication abortion services readiness plans.
And we've heard testimony from our two public institutions, so.
Right, you've heard testimony from the entities that would be affected by this, because the definition of institution is really University of Vermont and the Vermont, or it's currently Vermont
So
State.
there will
Health.
be changes to that section, and the Department of Health, again, has a huge role in there, and I think we'll be hearing from them about that.
It
Yes.
sounds like one institution is ready and one
One
is
is,
not.
one is not.
Right. Well, and really, these are readiness plans, so it's about how they are, what they're, I don't know that if plan is even the right phrase, because I think the way it's described is more about just setting forth their kind of their protocols. More so than having a plan in
Yeah.
place to get to a different level of service.
We might just want to have them come back and do the same thing that they did.
Maybe it's a semantic.
Right, and wondering if the word plans is.
Freaky.
Plan made.
Yeah.
Go ahead.
I was just curious if legislative council has a reaction to the testimony this morning about, from the young lady who was discussing the constitutionality of not including pregnancy services in the same message, same bill. I'm wondering if there's if there's a reaction, from a legal perspective, a reaction to her comments.
I mean, I certainly haven't researched it. At first blush, I think it's really a policy decision to make. I'm not sure there's necessarily a constitutional requirement that you cast a broader net. But I want to look into that more, or I'd be helpful to hear some more detail. I think people often throw around the terms constitutional or unconstitutional. It'd be helpful to know which constitutional provisions people are particularly pointing to and what they believe is the nuance to that provision that would be affected by the language in the bill. I'm happy to review anything that
Review that.
sure, anything that somebody wants to put forward with a particularized constitutional concern.
I mean, it does broaden,
No, I don't. I
I
had
mean,
the same
I can remember I had students who became pregnant and some of the work that I did with them and then referring them to campus counseling and how their decisions were being made. And then I can remember students who gave birth in the dormitory without any support whatsoever. It was really sad to see, but they did it. And so there's a whole breadth of what happens within any given sort of community environment, municipal or otherwise, so neighborhoods, college dorms, whatever. So it's a big discussion. And I don't know what it's, I mean, we heard a little bit today from UVM, what it's like. We haven't heard a whole lot, so.
I mean, I think section 2502, as I read it, which I think is the section that was being pointed to, is, you know, we talked about whether the word plan is the right word or not, but this is really looking at kind of a status report.
The status report, you know, an update,
what is the status of the ability to
I'm
provide
interested,
certain
yeah,
services?
and what are the numbers, you know, how many students are being served and how many are not, but what's the need at the campus?
Right, so I certainly think, you know, there's a policy decision to be made if you want to broaden the scope of what these institutions would be reporting or providing information on. I don't think there's any problem with expanding the scope, but I'm not sure there's a constitutional mandate to do that.
Yeah, I mean, we could, if there are concerns, you can just say gender affirming healthcare and reproductive healthcare. And, you know,
Yeah,
and
procedures,
that
services.
right now, it's very specific to medication abortion, and you know, we could broaden it to be reproductive healthcare.
Reproductive healthcare. That answers your question.
Absolutely.
And so, and the Department of Health is gonna weigh in on this, and they may be helpful, and they're always helpful. So they might be helpful in helping us.
Are they always?
They're always helpful.
Sure, they would be pleased to hear you say that.
There's a burden, we just place a burden on their shoulders. Okay.
All right, so that was those couple of sections together on those readiness plans, or whatever term we want to use for that. Then on page 20, we get to the prohibition on disclosure of protected health information. And this is,
Can I ask one question before we,
Sure.
just kind of the staging your sequence? So on page 20, lines 1 through 5 that discuss the plans are adequate. How do we define?
Well, we could change the language. We don't know what's adequate. But we want to know what the need is and if is the need being met on campus. I think that's where,
So,
yeah,
so further question.
yeah.
Um,
Keep going.
Why are we limited, why are we focusing on campus specifically as opposed to community? I understand that goes back to the other report about surrounding areas and 50-mile coverage and such, but I'm wondering if, for example, the state college group that came in and talked about, you know, that they essentially defer to the community, to outreach to the community. What is adequate? Is that adequate on campus or is adequate, you know, surrounding the?
So in the case of the higher ed, there are 2 public institutions. And so, you know, you have a cohort of young people who may be at risk. So that's why they're included. And then the other section is to get an understanding of what's available in the broader community. So that's what we're doing there. Yeah, so, yeah.
Can I add?
Sure.
Vermont actually has the highest concentration per capita, I think, of college age students, 18 to 22-year-olds. We have, if you look at our population numbers, we have a much higher, and then it drops down because people come into the state to go to college
Right,
here.
all over that.
And so I think, you know, as Senator Lyons said, having these concentrations of young people, especially in parts of the state that may not have adequate health services for these types of health services, it's really important for them to be able to do that. And frankly, it sounds like the state colleges haven't really done what they should be doing in order to make sure these services are available to their students. And given the age group, they're more likely to need it than you or I, for example, because just of where they are in their development lives.
That answer. Okay.
Okay, and then we get to section 14, which I think is the last substantive section in here, and this is the privacy provisions or some prohibitions on disclosure of protected health information. And as I understand it, you heard some concerns or some questions yesterday about this. So I am happy to work and would like to work with some of the stakeholders to understand the issues and get their help in tightening up the language to make sure it works the way.
One comment in particular from the Medical Practice Board was the narrowing of language. Number 3 and 22. We'll have to look.
Was to make sure that we can also share it among providers.
Right, I mean, there was some interest about sharing among providers also, which I'm not, we'd have to look, but there, the settings on these are fairly contained. But I know we've heard reference from a couple of stakeholders about including business associates, I think, along with the covered entities.
Oh, right,
And that was
that's
the case
right.
From Vital, that's on your website, and one of the other, what I understand from Amber's notes from yesterday, somebody else had raised the same issue, so I can also talk to those interested parties about where and how that should be folded in.
Yes. Okay, and then I'm looking at some other. The other one was the comment about medically appropriate language.
In the disclosure piece, or are you?
No, not.
Okay.
Well, medical necessity and the definition.
Medical necessity was the piece we talked about keeping in the coverage and not confusing what's legally protected with what's required to be covered.
Got it, okay.
The other comment I remember from this section was about making sure that the exceptions here on page 22, in the circumstance where we're talking about when there's been a claim against a covered entity, that making sure that they can share the information not just with their attorney and professional liability insurer, but anyone who they would need for defending themselves as part of the suit.
Right.
I don't know how you want to address that, but that was the concern that was raised, that it might be, you might need more than just the attorney and the insurer.
So this is under the section on the rules, the Supreme Court rules. Where are you?
This is
You're
under
under
22.
Right underneath that, yes,
Right.
under division 2.
Yeah. Okay. All right, well,
So I will look at what's on what the committee received yesterday in the way of written testimony, but certainly if there are people you've heard from who want to be in touch, I'm happy to work with folks on tightening this up.
So Alex is going to reach out and make sure that we have all the testimony in writing, get that up on our webpage, because we can't do the work without it. And then next week, we'll be taking more testimony on Tuesday. And on Wednesday, we're going to start a markup and walkthrough. Is it Wednesday we're doing that?
Yes.
And then on Friday, we're going to finish we're going to do more markup and hopefully get to some close to closure on the bill.
Do you think we could hear from some students at UVM and the state university campuses?
Oh, we can talk about that. I mean,
I'm just curious, their perspective on how ready their campuses are, for example.
We can talk about that. We'll see what we can get.
Okay.
So I'm gonna work with Ameren and Jen and try and go through some of the things that we've talked about today and maybe get some language to bring back so that we can look at it as we go through the bill. It's a big job. There's a lot here, and H89 is on its way over, so we have a lot to do. We've heard a lot of testimony. I'm trying to say, students maybe, And then we'll see where we go after testimony from the Department of Health. And who else do we have? Well, we have the compact person coming in, Alex, and
We have Crisis Pregnancy Center.
Crazy.
testimony.
Okay, thanks. There it is. So we've got on Tuesday, we have the Crisis Pregnancy Centers coming in. We have the Executive Director for the Interstate Medical Licensure Compact Commission. We have the Medical Malpractice Insurance Representative, and we have the Ethics of Information for Patients from the Clinical Ethics, Vermont Ethics Network. So that's on Tuesday. So that'll really be some fine tuning of testimony. On Wednesday, we're going to walk through H89, the areas that are specific to us with our ledge counsel, Michelle Childs. And then we will also be going back and doing some markup for part of the time on Wednesday. And I'm gonna scoot ahead, and on Friday, we'll do more markup on the bill. So we still have testimony we're taking, and then we'll be doing markup on the bill. Lot. Good. It's good. I think, we'll make some progress. I think after we look at some of the language proposals based on the testimony that we have heard, and then we'll get the testimony and we'll add that in, then we'll be moving right along. Our goal is to get the bill out ASAP. Okay, so we'll go offline and we're gonna wrap for the day.